So without further ado, I'm going to go to Rick Moss, who qualified as a pediatrician in Columbia. He qualified in medicine in 1971, about the same time that I did. He became a pediatrician in Chicago, and his postgraduate training then was in allergy and immunology and lung disease at Stanford. He joined the faculty in Stanford in 1981 and became director of the Cystic Fibrosis Center in 1991. And he was telling me that he had a Cystic Fibrosis Foundation conference where the Cystic Fibrosis Foundation chaired a conference, a consensus conference for Aspergillus and cystics in 2003. So I'm very pleased to welcome Rick to the podium here.
Hello, I'd like to thank Dr. Scott and the other people in the Fungal Research Trust who organized this patient meeting to deal with the problem of Aspergillus in several different areas. My talk is going to be on cystic fibrosis, although a lot of what I say will also be applicable to people with asthma, as you'll see. So the title of this question, how important is Aspergillus in cystic fibrosis? Is it a real problem? What is the problem? How do we deal with it? How would a patient approach seeking out the best care? Well, let's start just by remembering how people get sick from Aspergillus. Aspergillus reproduces by producing tiny little spores or seeds that are microscopic that can be put into the environment, into the air. They can stay in aerosol form. They're small enough so that when you breathe, you can breathe them deep into the lung. Yet they're large enough that they don't go all the way to the air sacs in general. Unless they're broken up, they'll wind up somewhere in the airways. If you have no underlying lung problems, then you'll be able to rapidly clear these spores out. And if you're an allergic person, you might develop allergy, but you won't develop a situation where the spores can start growing. But if they do have a chance to grow, and that can happen to people that have compromise of clearance of secretions from the lung, and that is a fundamental problem in cystic fibrosis, and it also occurs in people with poorly controlled asthma, then these spores can germinate, can start to grow, and that's when you get more serious illnesses. They like to grow in body temperature, and that may be one reason amongst several that Aspergillus is a particular problem for both lung infection and lung allergy. We know that Aspergillus can grow in these patients because if you get a sputum sample, you can actually see the growing hyphae, which is the growth phase of the organism actually in the sputum, and this picture shows you a micrograph of that. And it's very easy to identify Aspergillus from amongst the large world of fungal infections by its characteristic shape and size. Now, what about cystic fibrosis? Most people who have cystic fibrosis are very familiar with the symptoms. They're usually getting specialty care. In the United States, this is well organized, and I think it is in most of the EU countries also. But if you don't have cystic fibrosis, then it's likely you may not know much about it because it's relatively uncommon. Even though it's the most common lethal or life-shortening genetic disease in Caucasians, it's still fairly rare, about 1 in 4,000 live births. That, however, results in a group of people that is well over 70,000 worldwide. And as we learn more about CF, we are beginning to appreciate that it's probably much more prevalent than that because we've just begun to identify what CF is in other patient populations, in particular in South Asia. How do you get it? Well, it's a genetic disease. So you get it by inheriting it. And it's one of those forms of genetic diseases that is called recessive. That means that you need to inherit a mutated or bad copy of the CF gene from each parent in order to have CF. If you only inherit one copy from one parent, you're what's called a carrier, and you're for all intents and purposes perfectly healthy. But if you inherit these two bad copies, then you can get cystic fibrosis. Now, CF doesn't look the same in all people because there are other genes that modify how it's expressed, and how serious the manifestation is, what kind of tissues are affected in the body. And there are also over 1,600 mutations within the CF gene itself that have some variability in how much disease they can cause if you inherit one copy of that and another copy of another mutation. The fundamental disease is caused by changes in the movement of salt and water across a number of tissues, including the respiratory tract, and that's why the sinuses and the lungs are involved in the disease. If you look at people with CF, looking at this picture here, you can see that several organs are affected, including the respiratory tract, and I'll be just talking about the lungs. But it's also important to remember that CF is a multi-system disease and quite complex, and different people have different health problems with it. You could have various gastrointestinal problems, including pancreatic insufficiency, diabetes, liver or gallbladder problems, and several other manifestations. Because of the problems in the GI tract, there's problems with absorbing enough energy, particularly fat-containing foods and fat-soluble vitamins. So you can get into problems with that. And in infants, you can have a salt loss syndrome, actual shock from the loss of salt in the sweat. In fact, the diagnostic test involves measuring the salt in the sweat. And then finally, almost all males with cystic fibrosis are infertile because they have an obstruction in the reproductive system. Focusing in on the lungs, this is two micrographs of lung tissue, and on the left-hand side, we see a normal airway, looking at it down the tube of the airway, and you see in the middle, it's clear, that's air moving there, and then it's surrounded by these cells, which are called epithelial cells, and beyond them, in the periphery of the picture, are the gas exchange units, the air sacs. If you look on the right-hand side, you can see an airway from a patient with cystic fibrosis here, and you'll see that that airway is clogged. And it's clogged, if you look at it carefully, with a lot of mucus, cells, these are inflammatory cells, white blood cells that shouldn't be there, and microbes. And that's where we're getting towards Aspergillus, because one of the microbes that tends to grow in the CF airway is Aspergillus. The focus of CF caregivers for many years has been on bacteria because they cause more acute respiratory infection and illness. But as we have become better at doing that, we become more aware of more chronic problems like Aspergillus. But it's the same problem of the organism growing in mucus that's stuck in the airways. Well, how common a problem is it? This is a table from a paper that was published relatively recently, which looked at a number of other papers around the world to try and get a handle on how frequently Aspergillus is found in this disease. And if you go to the right-hand side, you will see in the parentheses a list of numbers that represent the percent of patients that had positive cultures of sputum for Aspergillus. And you can see it varies quite a lot, from under 10% to over 50%. And part of that problem has to do with how frequently people are tested, whether special culture medium or growing materials are used to let the Aspergillus grow, and also what kind of patients you're looking at, because we know that this happens more frequently as one gets older. But I think it's fair to state that in general, a quarter to a half of patients with CF will, on any given day, grow Aspergillus from their sputum. And that's a very high number, because normally that doesn't happen. So there are some factors that have been associated with this positive culture. This is a paper from Johns Hopkins in the United States that's just been published online very recently. And what it shows is a couple of interesting things. First of all, they compared their information from the late 90s to just a few years ago, and you can see that it's increased dramatically from 2% to 28% in their particular clinic. Now again, that may be a function of more frequent culturing, better culture methods, or a real increase or a combination of those factors. They did find that age is an important issue. So it's relatively rare early in life, but becomes more and more common as you get older. And they also found that the more one treated the bacterial infection with antibiotics, the more likely it would be to have a positive culture. The next thing they found was that the disease severity was a factor. That is, people with more compromised lung function were more likely to grow Aspergillus. And then one finding that was somewhat of a surprise was the fact that in patients that were getting inhaled corticosteroids, which, as you may know, is the mainstay of treatment for asthma and also is widely used in cystic fibrosis, they actually found less Aspergillus, whereas you might expect more because in general steroids, as you'll hear later today, have been considered a risk factor for Aspergillus. Now, what's the problem if you have Aspergillus in your sputum and you happen to have cystic fibrosis? Until fairly recently, it was somewhat controversial as to whether it had any significance. And in fact, many clinicians, many treating physicians would just ignore the positive culture. However, information is beginning to emerge now that, in fact, this may be a problem. And that's illustrated in this slide. What you see here is information from a database, a collection of information from a very large group of patients at the Hospital for Sick Children in Toronto, Canada, which follows about 500 to 600 patients. And over a period of time, they track a large number of things associated with the illness in their cystic fibrosis clinic. And you see 4 curves here, which represent on this axis the age, increasing age, and on the y-axis lung function. And you can see that lung function is going down with age. These curves are going down this way. The 4 curves represent patients that are categorized into those that have Aspergillus or don't, and also those that have the most common bacterial infection, which is an organism called Pseudomonas, or don't. And the 2 arrows represent patients that are positive for Aspergillus. The yellow arrow points to patients that have Aspergillus but don't have Pseudomonas, and then the red arrow points to the line of patients that have both of these. And you can see for any given age, lung function is lower in patients with Aspergillus, and the combination of both the bacterial and fungal infection creates the lowest lung function. So this is telling us that just the recovery of the organism from the sputum is a relevant clinical fact and is leading us to think that maybe we should be treating this, which is not the current standard of care, actually. Excuse me. So right now there's a trial going on in Canada to use an antifungal agent to treat patients with CF regardless of symptoms based on whether or not they have Aspergillus in their sputum culture. Now, you'll hear more about the disease manifestations of Aspergillus as the afternoon proceeds, but I thought it would be useful to sort of situate what we're talking about in a broader context. Thank you. In cystic fibrosis, patients have generally intact immune systems. In patients that have poor immune systems, whether they're being treated for cancer or have some other problem like a transplant, they are patients that are prone to get invasive Aspergillus disease. And that's certainly one form of a problem that's very severe, but usually self-limited in time. It's a very serious infection with a high mortality rate. There are patients that have somewhat of a compromise in their host defenses, particularly in the lungs, based on some other disease like diabetes or whether they've had tuberculosis that weakens the lungs and allows a more chronic form of Aspergillus infection. In cystic fibrosis, we have patients that have very robust immune systems, and they tend to have allergic disease. So ABPA, which stands for allergic bronchopulmonary aspergillosis, is amongst a group of problems in people that have intact immunity. But it's helpful to think about CF as at one end of a spectrum of disease that can be caused by the same organism. How do we diagnose ABPA in patients with cystic fibrosis? Well, Dr. Scott alluded to the meeting that we had a number of years ago in the States to try and get a group of experts together to come up with some agreement about how to recognize this problem. It's not straightforward because it depends on several different things being present. And if you don't look, if you do not seek, you shall not find. So there's also the question of how diligently people are looking for this and are aware of the problems. First, you have to have a clinical deterioration, and in a patient with cystic fibrosis, That means someone who starts coughing more or wheezing more, having more shortness of breath, more difficulty with exercise, wheezing, lung function dropping down when measured, and increase in sputum. Often appetite will be bad, and sometimes there's fever, but those are not always seen. In that context, if someone has an elevation in a blood allergy protein called IgE to a quite high level, that raises a very high suspicion for this disease being present. But that's not all. We then need to show that a lot of the immune system reactivity that's sort of reflected by that high IgE level in the blood is due directly to Aspergillus, and that can be done in one of two ways. You can either do an allergy skin test on the patient, usually somewhere on the back or the forearm, or you can take blood or use the same sample and look for a specific IgE antibody against Aspergillus. So you have to have some evidence of specific allergy to Aspergillus in addition to the other things mentioned. And besides the IgE response, which is associated with allergy, like allergic rhinitis and asthma or other allergic diseases, you also need to show a more general immune response to Aspergillus by making another type of antibody called IgG. And there are several tests that can be done on the blood to detect that also. That can be done, or you can show changes in the image of the chest, that is the chest X-ray or the chest CAT scan, which show a new problem. And in cystic fibrosis, the lungs are abnormal to begin with, so we don't say any abnormality, but we're talking about a change or a worsening from particular baseline. So that's the constellation of findings, and you can see it's quite complex. It's not as if you take one simple blood test or do a throat swab as you would for a strep throat and you have your answer right away. You have to put together and assemble several different things, not so easy to do. It's made more difficult by the fact that in cystic fibrosis, patients have a number of features that also cross over into ABPA. So let's go through this very quickly. About half the patients with CF already are allergic to Aspergillus without having the full-blown ABPA. So if you do a skin test, that might be positive, or you can show allergic antibodies in the blood. About a quarter to a half of patients with CF have an asthma-like quality to their disease. That is, they wheeze, they get shortness of breath, they get relief from bronchodilators like salbutamol. They may respond to inhaled corticosteroids. Patients with CF, by definition, have lung infiltrates. That's part of CF lung disease, and in particular, a form of lung disease called bronchiectasis, which is really a weakening of the airways so that they balloon out and look abnormal. You can see this very clearly on a CAT scan, not so easily on a regular chest X-ray. Atopy, or general allergic susceptibility, is common in CF, so not just an allergy to Aspergillus, but patients may also have allergies to other things that you're more commonly find in people with allergies like grass pollen or tree pollen, dust mite, cat dander, and so on. Many patients with CF have various kinds of antibodies to Aspergillus, and a fair number have elevations in the IgE. So what I'm saying is that a lot of the features of ABPA can be found in patients with CF who actually don't have the full-blown problem, and differentiating patients with part of the problem from those that really have the problem can also be tricky. There are some risk factors that we know about for this problem. I mentioned that you have to have basically an intact immune system, but there are various components of the immune system which can be inherited, which are shown on this slide, that modulate or alter the risk up or down, depending on what form of that particular immune system product you inherit. In addition, we know that the environment does play a role. If you live on a farm and you're turning compost or hay piles, you can get exposure to a huge cloud of Aspergillus spores, and that can make you sick. And there are other infections in cystic fibrosis that may predispose. Interestingly, we've now know for sure that people who have one CFTR mutation are at a higher risk for Aspergillosis than patients that have two normal CF genes. So I mentioned that carriers are generally healthy, but they can have a risk for ABPA if they also have asthma. complication important in patients with CF? Well, again, I showed you a little bit before that just having the organism present in the sputum culture may be a risk factor for more decline in lung function, and that can shorten your life further. If you actually look at the lung function in patients with CF who have ABPA, they appear to have more severe disease. So what this slide is showing you are two measurements of lung function in the two graphs, and the black boxes represent the patients with ABPA. And you can see if you draw a line through here, or a slope of decline, it's most severe for those patients with CF that have ABPA compared to other patients with CF, which is already a bad lung disease. So it worsens an already bad situation to have this. That's led us to believe that it's important to screen all people with cystic fibrosis for this complication because it occurs fairly frequently. About 10 to 15% of patients with CF will have ABPA. So one of the things that we recommended in the consensus conference was to screen all patients with CF starting at about school age by annual measurement of their blood allergy protein, or IgE level. And then if it's elevated, to pursue a further investigation. Even if it's below the arbitrary cutoff that we chose of 500 units, which is a measurement of how much of this protein is present, one could repeat that or follow the patient more closely if there was suspicion. This just shows the relationship between the IgE level, which is shown on the left here, and the lung function, which is shown on the right in the dotted line. And what you see is that as the IgE level goes up, the lung function drops down. This patient was actually a child of about 8 years old. When admitted to the hospital and treated for Aspergillosis, had a marked improvement in lung function, and the IgE level fell very rapidly and dramatically. And in fact, we can use this blood test as a very good indicator of the activity of this particular problem. So patients who already have ABPA diagnosed then are followed both by clinical signs but also by their IgE level, as well as some other measurements. IgE in particular being helpful in managing the treatment of the problem. This is a CAT scan. We're looking down into the chest. Imagine the scanner on the top of the head, scanning down into the body, and then you're taking slices through. And what you see here on the right, where the arrow is an example of what I mentioned before, namely bronchiectasis, which is an area of the lung where the airway has ballooned out and is no longer functioning at all. It basically is not clearing mucus and organisms and particles from the lung as it should. In other areas, these ballooned out segments of bronchiectasis become filled with mucus, and you get what's called a mucoid impaction, which is shown here, which shows up on a CAT scan as a very white area. Often it's actually even denser than the surrounding soft tissue, like the chest wall, because there's a buildup of certain metal ions in this material that cause that. So that's an example of a mucoid impaction or mucus plug in ABPA, and the organism is growing in these plugs. This shows a patient that has an acute episode on the left, and the same patient 2 weeks later after being treated for ABPA. And you can see, although this is not completely normal, it's vastly improved. You see these infiltrates or white areas in the lungs that represent areas of mucoid impaction and surrounding inflammation. That's markedly improved in just 2 weeks of treatment with steroids. We looked at patients at our hospital some years ago to look at all the patients we admitted with CF for treatment of respiratory infection, and basically found that about 10% of the patients had ABPA as either the cause of their exacerbation or infection episode, or as a concomitant infection along with bacterial or viral infection. So we feel that it's a fairly important thing to look for in patients with CF if they're going along and then get sick. Very important to look for ABPA. Now, turning to treatment, the mainstay of treatment for this has been systemic steroids like prednisone for many, many years, and that's still the case. And basically, any patient with this particular form of Aspergillus should be treated with steroids. Now, that's not the way to treat patients with compromised immune system, as you'll hear later. But for those with intact immune system with allergic disease due to Aspergillus, like ABPA, that is patients with CF or asthma, systemic steroids are important. And initially we give a very high dose of prednisone, which is a tablet, can be taken very easily or given to a child as a liquid, usually every day for 1 to 2 weeks, and then begin a taper by changing them to alternate day, and that's to reduce the side effects, and then to then taper off over a period of several more weeks. So a course of treatment in total will be 2 to 3 months. If you have asthma, you know that often people with asthma and exacerbation of asthma will also get steroids, but usually just for a few days. And this is an important distinction. People with ABPA need a much longer treatment with steroids than just a simple asthma flare. So one would then hopefully get the patient off, and they wouldn't need it again. But unfortunately, many patients who have ABPA will relapse. They'll have another episode. And if that happens, then you have to go put them back on or increase the dose or use another medicine, and then try and taper them later. Now, more recently, we've been able to use an antifungal agent very effectively for this problem. And this has been shown to be effective both in asthma and in cystic fibrosis patients who have ABPA, and that is to add an antifungal. Itraconazole is the most popular one. So the indications to use it would be to give patients that have a slow or poor response to steroids, or who get sick again, or who one cannot get off of steroids, or who develop serious side effects from steroids, of which there are many, unfortunately. And we use the itraconazole daily, twice daily for older people, and generally treat for several months, sometimes even longer than 6 months. You have to look at the liver function because this drug is handled by the liver. And due to a number of problems in cystic fibrosis having to do with absorption of the drug and also other medications, it's very helpful to measure the amount of the drug in the blood, which can be done very easily. Patients with CF have trouble absorbing. Remember, I mentioned that as one of the major problems. So itraconazole in particular is a problem. And we need to give it with some acidic drink like cola. Many patients with CF take various kinds of antacids to reduce the acid in the stomach. So we have to work around that problem. And they may be on other drugs that are also handled by the same systems in the liver that detoxify itraconazole. So you have to know about those, and you have to monitor or adjust the dose accordingly. So itraconazole is certainly not a perfect drug for cystic fibrosis or other situations where you can use an antifungal, and there are newer antifungal agents such as voriconazole and now posaconazole which are available. We're beginning to get some experience using voriconazole for this problem in cystic fibrosis, and I just show on this slide 2 studies. You can see they're fairly recent, looking at the use of voriconazole. In cystic fibrosis, in general, they've been tried mainly on patients that had trouble with steroid toxicity, and some improvements have been noted, but I think we're still just getting experience with this. Voriconazole is much better absorbed than itraconazole, but the difference between different people in terms of how that translates to the level in their bodies is very large, much more so than for itraconazole. So again, the use of blood levels can be very helpful in knowing whether or not you're getting the right amount of voriconazole for treatment. This is a study from Ireland, which shows the effect on the IgE level of using voriconazole, and I mentioned before that IgE is a very good guide to how the patient is doing. And you can see the total bar, which is reflected by the blue plus the red, is the IgE level at the beginning of treatment. And then when voriconazole is used, you can see in almost all cases is a very dramatic improvement in the IgE level. And other information in this paper also showed that lung function and other clinical measurements also helped. So we know that voriconazole can work well for ABPA. But for various reasons, there may be patients that don't respond fully to either itraconazole or voriconazole. We don't have experience yet with posaconazole, another oral antifungal drug. So there is an alternative, which is to use amphotericin, which is a very toxic drug that's been used for many decades to treat invasive aspergillosis. but give it by aerosol so that very little gets into the rest of the body and most of it gets into the lungs. This has been used for a very long time. Most of the experience with it is for people who've had lung transplants or have various forms of cancer and develop Aspergillus problems. But there has been some use also in cystic fibrosis patients with ABPA, and there are studies that show that there are ways to deliver the drug in the amount that can get enough into the lungs to kill the Aspergillus that's there, and actually is fairly well tolerated in those patients that we've tried it on. So even though there are no extensive studies of this, it is an alternative for people that are having a lot of trouble with other forms of treatment. I mentioned steroid toxicity, and one of the ways that people have tried to get around toxicity from taking prednisone for a long period of time, every day or even every other day, is to try and give the steroids one big whopping dose just once a month. So there are now several reports of this, one from the UK and another one from a combined Israeli and UK study that are shown on this slide. And basically the point is that these are all patients that had very serious steroid toxicity, couldn't get off of prednisone, and were therefore placed on this pulse IV steroid regime. And there were some improvements noted in some of these patients. Again, this is a small number of published cases, but it's promising, and I think it's something to consider if you have this problem and have a lot of problems with prednisone. There's a final treatment which is interesting, and that is based on the experience in asthma. There is a drug called omalizumab, which is marketed as Oler in the USA. I don't know the name that's used in other countries, which is a monoclonal antibody that's targeted at the IgE itself. And in asthma, this can be quite helpful because what the drug does is to bind IgE circulating in the blood or in the tissues and sort of removing it. When this anti-IgE and the IgE get together, they're then removed from the body by a mechanism that clears large proteins. So that reduces the amount of IgE, and it also actually reduces the amount of the IgE receptor or place that the IgE will bind to the cell that causes allergy. And the net result of that is that when the person with allergy is exposed to the thing they're allergic to, less allergy chemicals are released by these cells. So the clinical thing that you see is a reduction in asthma attacks in people that are on Xolair for allergic asthma. So the thought is that maybe this would also work in ABPA. The problem is that there are several problems. One is that this is a very expensive drug. The cost-benefit analysis really shows that it needs to be very highly targeted to people that cannot be managed in any other way. Their asthma is just out of control without it. And we don't know if it works in cystic fibrosis yet because the IgE level is so much higher in most patients with ABPA than simple allergic asthma. However, there have been some preliminary studies in patients with CF that show, if you just look at the top part of this, you can see that there's a reduction in exacerbations in these 3 patients once they started taking Xolair for their ABPA. And their lung function in general trended upwards. That's what all these squiggles are about here. So they were able to get off of prednisone with their Xolair therapy and have reduction in exacerbation and improvement of lung function. Here's another case where the treatment is started here and the person's lung function improves very dramatically. So this doesn't prove the point, but it gives enough lead information to justify what's called a controlled trial, which is now being run to look at this. We're using a mock drug or a placebo in some patients and actual drug in other patients. So let me close by just referring to a couple of important points I hope you can take away. ABPA is a problem of Aspergillus that generally occurs in 2 main categories: people with cystic fibrosis, about 10 to 15%, and people with asthma. The number of people with asthma that have ABPA is unclear. Again, the harder you look, the more you're likely to find, and some recent studies suggest that it's much more common than people have thought about. 5% of asthma is a huge number of people when you consider that asthma is one of the most common chronic illnesses in the world. But the only way you're going to really know about this is to really have what we call a high index of suspicion. That is, think about it, at least in these two sets of patients, and do the appropriate tests that I mentioned to diagnose it. In CF, we're aided by the fact that CF care is organized into care centers. Patients are followed fairly carefully. It's easy for us to get that annual IgE level and have a baseline to know if there's been a sudden shift upward. The criteria for diagnosis, I didn't go into the diagnosis in asthma, but it's not quite the same as in cystic fibrosis. But both Aspergillus infection and ABPA are important contributors to the overall picture of CF lung disease. We still rely on steroids as the mainstay of treatment, but there's lots of problems with side effects, and that's led to the use of these other agents that I showed you, including most prominently the antifungal drug itraconazole. But we are looking at these other alternative agents, including other antifungals such as voriconazole or inhaled amphotericin, the use of steroids in a less toxic way by giving it intravenously once a month, and the use of anti-IgE or omalizumab. So I think I'll quit there. And do we have questions right now or wait till the end?
If you stay there, thank you. Okay. Rick, thank you very much indeed for a very clear exposition on this. Are there any questions from the floor? Now, there are some microphones here, so please don't be shy. There's a question there, please.
Rick, hi. I'm Mike Gray. I'm a physician in Arizona.
Hi.
I've been looking a lot at the issue of environmental factors also, and was struck by a couple of things. Number one of the recent directors of HUD in the United States indicates that approximately 25% of all residences are excessively contaminated with fungus as a result of damp conditions and just deteriorating damage. I wonder if it would be considered beneficial to have patients who are suffering from either cystic fibrosis or Aspergillosis and bronchopulmonary aspergillosis, allergic bronchopulmonary aspergillosis, consider using Sabaru auger plates and testing their home by a very simple matter of just exposing them for a couple of hours. According to Donald Dennis, if you accumulate more than 4 colonies per hour on these plates of any form of fungus, it's almost impossible to treat or cure sinusitis and sinus-related illnesses, but there may be a corollary here with folks who have both cystic fibrosis and the bronchopulmonary aspergillosis issue.
Thank you.
Yeah.
Hold it there.
Sure.
Rick, do you have an answer for that?
Well, I think that you have a point. There's not a very well-developed scientific literature on the relationship of exposure to ABPA in particular. But certainly I've had cases where people who have already developed the problem have traced back to their home or work environment exposures that could be eliminated or at least decreased. So one example was a person that lived in a rural area and liked to ride horses and took care of the horse themselves and would go out to the barn and turn the hay pile. And with a little detective work, we figured out that these episodes were actually related to these exposures to clouds of Aspergillus. The chronic indoor exposure, I think, is more difficult to deal with, and I know it's been a subject of a lot of investigation and some controversy about what the meaning of recovery of these are. I would just say that if a patient does have ABPA or serious allergic fungal asthma, that some investigation of the home environment or the work environment could be helpful, or occupational environment. In fact, it's a risk factor in hospitals where construction is being done that Aspergillus outbreaks have occurred. And in the States, there's a very active surveillance, and construction is done with a great deal of care to try and avoid exposing, in particular, the immune-suppressed population. So there are definitely environmental issues that are involved with this disease, but it's a little hard to get a handle on the meaning of the indoor exposure that you'd get from a mold culture in the home. So I can't say anything definitively about that.
That's very helpful. And Malcolm's going to talk a little bit about the environment at the end of this meeting, which will be very useful, and I hope that will begin to answer some of your questions. It raises the issue in my mind as to whether the patients who are colonized in your group continue to have the same Aspergillus year after year, colonizing their lungs, and then, or whether the allergic component is a reflection of new inhalation of spores. Do you have any thoughts about that?
There have been some publications using DNA testing to look at the genetics of the organism, which gets at your question. And although that's not an extensive database, is not a huge amount of information, it looks like once you get a particular strain of Aspergillus that you will tend to keep that strain and not have it replaced by another one. So we're assuming that each patient in general has their own form, their own strain, their own genetic clone of Aspergillus that's causing them their problem. And that's very similar to the bacterial infections that we see with organisms like Pseudomonas, that you get from the environment an initial strain. If you have CF, you tend to keep that strain for years to decades.
And why then do you think that they get worse? Why do they have exacerbations? Is it some other infection? Is it a virus infection, or?
That is a great question that I don't think we know the answer to.
Okay.
And it may well have to do with tipping the balance by an intercurrent viral infection, but there's really very little information about that.
Right. Are there any other questions? Yes, there's one here at the front, please.
Thank you. I am Gilbert Massat from Strasbourg in France, and I'm basically a thoracic surgeon and involved in lung transplantation. So I'm very admirative of the results which are achieved at your institution, especially by Dr. Starnes and Dr. Cohen, including living lobar lung transplantation. My question is, how do you consider Aspergillus infection in end-stage lung disease? Is this an impediment to lung transplantation in your opinion? Or if not, which kind of specific measures would it require?
Another very good question. Basically, you're asking, should we try and get rid of Aspergillus before we do a lung transplant? This was the attitude that our transplant group took for quite a number of years. And it's what got me into the use of inhaled amphotericin, because we were rarely able to get rid of the Aspergillus using itraconazole. But when we gave inhaled amphotericin, we could often get rid of the Aspergillus. The question was that really necessary? And other groups have now published, I think fairly convincingly, that it didn't affect their overall outcome for lung transplant. So our group has stopped using that criterion. And we no longer have to try and get rid of Aspergillus in our patients before they undergo lung transplant. If they have ABPA, they also can get a lung transplant. But the complicating factor there is how much steroids they're on. So we try and minimize that to the point where it's acceptable to the surgeon. So I think in both cases, having Aspergillus does not need to be eliminated in order to qualify for lung transplant, and having ABPA is not a contraindication either, but there are certain parameters that you have to follow to optimize the outcome.
Thank you. What an amazing question. Excellent. And a lovely answer. Thank you very much indeed, Professor
Thank you.
Moss.